The next speaker in this session is Professor Udaya Ranawaka, well known to all of us. He is professor in neurology in the Faculty of Medicine, University of Kelaniya. And he's going to speak on an interesting topic. We as doctors and physicians, we assume that we know what death is, but I think Udaya has a different story to tell us. What is death? Udaya, over to you.
Good afternoon. Thank you, Chairperson, sir. And I would like to thank the Council and the President of the Ceylon College of Physicians for this opportunity to talk about death. And quite appropriately, they have selected somebody in the departure lounge to give this talk. And death has fascinated us from time immemorial. And mankind has been troubled and haunted by the prospect of death and by the question, what is life and what is death? And many a great work of art. One I have shown here, the painting by William Hogarth of Satan and death fighting at the gates of hell, with sin trying to intervene between the two, based on the epic poem Paradise Lost by John Milton. And we, over the years, for centuries, we have had trouble coming to terms with the diagnosis of death. And we have never really reconciled ourselves with the question, what is death and what is life and what are the answers to that and how can we discriminate between the two without any uncertainty. And even here, as you can see, King Lear was lamenting the death of his daughter Cordelia, and he's trying to look for signs of life in her dead body. So if I were to ask you a very simple question like, are you dead? The answer has to be a very clear-cut yes or no, hopefully. And there cannot be even a response of maybe. But let's see why I have put it there. So what is death? Death can be diagnosed using three main criteria, three main sets of criteria: somatic, circulatory, and neurological. The somatic criteria are the ones that we have been using from time immemorial, looking at the external features of the body, decomposition, rigor mortis, etc. And people never trusted, just like nowadays. Even those days, people did not trust a diagnosis of death just because somebody said so. And there were fears of premature burial. So which led to the development of waiting mortuaries. And just look at the quote from George Washington saying, don't bury me at least for 2 days after I'm dead. And there were coffins built with inbuilt alarms and air supply and flags to be waved, as you can see on the picture here. So we had never really come to grips with the diagnosis of death, which then led to the development of circulatory criteria, which was pioneered by Bouchou in 1846 when he advocated the use of the stethoscope to diagnose death by listening to heart sounds. And the neurological criteria came into being with the development of mechanical ventilation and intensive care. And it was in 1965 when the term brain death first came into being. The foundation for brain death as we know today was laid in 1968 by the ad hoc committee of the Harvard Medical School when they defined irreversible coma as the criterion of death. And on the same day, coincidentally, on the same day, it was released, the World Medical Assembly released their Declaration of Sydney on human death, which again emphasized the importance of neurological criteria for death. In 1981, there was some legal backing given to the diagnosis of brain death in USA, where death was defined as the irreversible cessation of circulatory and respiratory functions or cessation of all functions of the entire brain, including the brainstem. The physicians in the UK wanted to differ. There has always been this transatlantic divide. So they adopted brain stem criteria rather than a whole brain formulation. The diagnosis of brain death, as we know today, is based on this practice parameter from the American Academy of Neurology, where they outlined the core clinical features, the three clinical findings of coma, irreversible coma, absent brainstem reflexes, and apnea, which is the formulation which is widely used in different formats all over the world as of today. So if I were to tell you, I'm going to use these criteria and tell you that you are dead, are you dead? Let's look at that. The first thing we would come to notice is that patients who have been declared brain dead continue to show traditional signs of life, like warm and moist skin, and their hearts continue to beat if they're on a ventilator. And if they're on a ventilator, they can maintain bodily functions for weeks and sometimes months on end. They can have growth and sexual maturation, and especially they can even have a healthy fetus growing in a pregnant woman up to even 12 weeks. There was one study where they looked at cases of diagnosed brain death, and they found 175 cases where the cardiac function had persisted for more than a week. And in 60%, cardiac function had persisted for more than 1 month. So clearly, there is evidence of bodily activity in people diagnosed with brain death. And there's residual brain activity, not just bodily activity. There's residual brain activity even in the diagnosis of brain death. This is well known. There's especially hypothalamic functions such as osmoregulation, thermoregulation, intact hypothalamic pituitary axis leading to secretion of pituitary hormones and autonomic reflex, especially things like hypertension and tachycardia when they are opened up for organ transplantation. And there are many other signs which are perhaps not so definite of CNS of brain origin, more likely to be of spinal origin, like the Lazarus reflex. So we had never, for centuries, we had never accepted the diagnosis of death on face value, and we had looked at other means of confirming death, like in the olden days, using a mirror or a feather over your mouth and the nose to see whether there's any evidence of breathing. But now we can do a lot better. We can look at brain function and see whether there are confirmatory evidence of either the electrical activity or the cerebral blood flow. Why the cerebral blood flow? What you would expect is when there's brain death, there's going to be a severe amount of edema, raised intracranial pressure, which will exceed intraarterial pressure, and the blood flow to the brain would cease. As what you can see here on the top panel is an isoelectric EEG. In the middle is a radionuclide scan where there's a hollow skull with a hot nose indicating loss of blood into the cranial cavity, which is shunted extracranially, especially to the nasal epithelium. And in the lower panel is a PET scan with glucose metabolism. As you can see, it's totally empty when there's brain death. So even if you look at confirmatory tests, you will see that there's persistent activity even on ancillary testing in people who are brain dead, both electrical activity and cerebral blood flow. 20% in one case series had persistent EEG activity, and 1/3 of brain dead patients had residual cerebral blood flows, residual perfusion in the brain on SPECT. So clearly there's something wrong with the criteria that we are using. Now, add to that, there's considerable international variation in the criteria that are used and also in the way we use those criteria to diagnose brain death. First, of course, is the concept of brain death. Is it whole brain death or brainstem death? Some countries, such as the UK, Canada, and India, use the brainstem formulation, which is practiced only in a minority of countries, about 13% in one international survey. And most countries use a whole brain formulation. And I'm sure you may not know, but this is what we are supposed to use, not brainstem death in our country. And the criteria that are used, unfortunately, to diagnose whole brain death is capable of only diagnosing brain stem death, and they cannot pick up higher brain functions. And clearly, there's a huge amount of variation. There have been several international surveys over the years in this millennium. All of them have consistently shown that there's huge international variation in the criteria that are used. Just a couple of examples from this 2002 study. Apnea testing with the PCO2 target, which is mandatory, was there in only about in 60% of the countries. And the observation period before confirming death and the number of physicians who are required using confirmatory testing all varied with a large variation. 2015, it's the same thing that you see. There are large differences in the practices of brain death in the way apnea testing is done, the observation time required, the number of physicians required, etc., etc. And more than half of people who were surveyed, they said that they deviated from the accepted American Academy of Neurology criteria, which is the criteria that was in place. And looking at the use of ancillary testing, again, you can see that there's a large variation. What you see on the graph in green are countries where those tests are mandatory, and optional is in orange, and red is where they are not required. And only 5 countries did not require ancillary testing for the diagnosis of brain death. They were mandatory in 22 countries out of 91 countries that were surveyed, and optional in others. EEG is the most widely used ancillary testing across all studies, and seen in about 75% of the protocols in this study. But to date, there are no established EEG criteria for the diagnosis of brain death. Let's move on to 2020. Have things changed? No. It's still the same. And still, if you look at the brain death protocols, 10% of protocols did not require coma, which is a fundamental requirement. And apnea testing was not required in 9% of the brain death protocols. And if you look at, there are any amount of data showing huge variation. 100% consensus was not seen on any aspect of brain death criteria among the protocols. And the authors pleaded for medical standards for diagnosing death to be uniform across the world. Having the criteria is one thing, but even if you have the criteria, what we see is that there's a huge amount of variation in applying the accepted criteria. There's just one study from the United States where they looked at brain death determinations in people who were organ donors, where you would expect the criteria to be used would have been a lot more stringent. Apnea testing was completed in only 73%. It was not even attempted in 21%. And more than half of the death denominations did not comply with the guidelines. Which begs the question, is the concept of brain death to serve the purpose of organ transplantation? Which Dix, who documented the proceedings of the Harvard committee that pioneered the concept of brain death, wrote that there were, even at that time, perpetuation concern that the transplant physicians on this committee had a major role to play in the definition of brain death. And Beecher was the chair of the committee, and he had posed this question, which was followed up in some of the correspondence, which was reported in this article. And he posed the question, can society afford to lose organs that are now being buried? So that seemed to be the thinking behind the concept of brain death. These are a couple of case reports, and there are many more like that in good literature, documented cases where organs were harvested from patients who were breathing. Case 1, the donor began to breathe spontaneously just when the liver was taken out. And the anesthetist found out later that at the end of apnea testing, the patient had started breathing, but the surgeon had said, okay, brain death criteria are met. Second case gets even better. Anesthetist noted that the patient was breathing when he was on the table. But then one of the physicians overrode the anesthetist and said, because the patient is not going to get any better, let's take the organs out and we'll declare him brain dead. So they removed the liver for transplantation while the patient was breathing. He even got tachycardia, which had to be given sedation to control. He died, and the liver recipient also died. And there are many more cases like this. So it's no wonder that the public and the patients and the families are suspicious about this whole concept of brain death. And if you look at the last line, that's really interesting. People are very happy to donate the organs of their relatives, but not their own. Dosito, at the turn of the century, wrote, ethically, organs should not be taken out from bodies where there is life. Sounds simple enough. But the fact that he had to put this down in writing in a major journal article is evidence enough that there is something seriously wrong with the concept of brain death and the way we diagnose brain death. So where are we now in the 21st century? Sorry, it's not coming up here. There's a problem with the, yeah, okay, right. So this is the story of Jahi Makmat, who was a 13-year-old kid who went into surgery, tonsillectomy and palatal surgery for obstructive sleep apnea. She had major bleeding, died of a cardiac arrest, was declared brain dead, but the parents fought the hospital. They went to courts and got a ruling for her to be transferred to another hospital. So what happened after a long legal battle was that she was allowed to move from a California hospital to a New Jersey hospital. Why? Because just like what we saw, you can be dead in one country and alive in another. In the United States, you can be dead in one state and alive in another. So the moment she crossed the boundary of California and went into New Jersey, from being brain dead, she was not brain dead, where she was maintained for more than 5 years after the original diagnosis of brain death using the most stringent criteria. So clearly there's something wrong. Even though brain death is a very widely accepted concept, there is persistent controversy and confusion regarding the diagnosis of brain death, as you can just see by the headings of these articles in some major journals. So what has happened this year is that the World Brain Death Project, which is convened by several professional organizations, released their consensus statement a couple of months ago, which surprisingly is the first international document to address brain death. And they have come out with some recommendations for minimum clinical standards, and they recommend a change in our terminology. Stop talking about brainstem, more whole brain death, and stick to death by neurologic criteria. They recognize the persistent confusion, the dilemmas, the inconsistencies in diagnosis, and the variance in practice. And also, perhaps importantly, for the first time, they recognize the importance of religious, cultural, and legal situations in different countries. And importantly, they point out the possibility of false positive diagnosis of brain death when we use brainstem criteria in primary brainstem pathology. So you can have a false positive diagnosis. So if I were to ask you, ladies and gentlemen, would you be happy to diagnose something so fundamental as death using a test or criteria with less than 100% sensitivity and specificity, and to accept a false positive diagnosis when it comes to death? I don't need to even ask you, I know the answer. So this is on your right-hand corner is Miracle Max from the movie Princess Bride, played by Billy Crystal. And he was spot on when he said that if you are mostly dead, you are slightly alive. So that is where we still are. Chairpersons, ladies and gentlemen, what I tried to do today is to pose you the question, what is death and what is life? And for centuries, we have been grappling with this question without a clear answer. And I have been fascinated and we have been haunted by this question. And as we can see here, almost 500 years after John Milton wrote his epic Paradise Lost, We haven't still come to terms with the diagnosis of death. We still don't know what shape it takes. We know the fear, we know the fury, we know the ferocity, and we know the darkness of death, but we still don't know how to confirm death with 100% certainty in this 21st century. That is where we are. So if I were to ask you, are you dead? If I were to tell you so, based on the criteria we have, I guess many of you might not be very certain and say, maybe. Chairpersons, I rest my case.
Thank you, Udaya, for that much interesting talk, though death is not an interesting topic, but you made it very interesting and exciting. I think this is the kind of thing that needs a lot of discussion, but I think being plenary, we kind of won't go into that. Thank you there again, and wish you a much longer stay in the departure lounge. Don't be in a hurry to leave it. Thank you.